Over the past 6 weeks, I've been redeployed to intensive care. As COVID's slowly winding down, I've seen a lot of trauma patients and specifically bleeding patients. I want to share here what I've seen and learnt in a few minutes. You can think of the body as a large container of approximately 4 to 5 litres of blood. You can lose and gain blood. Firstly, follow TLS Principles. This includes C-spine ABCDE. You need 2 large bore IV access cannulas. You'll need to think about a central line, arterial line, urine output, and increasing the level of nursing, such as HDU or intensive care. Next, you'll need to send bloods. This includes a full blood count, coagulation, screen, and group and save. Remember PT, APTT, platelets, fibrinogen, and TEG in the coagulation screen. The principle here is to replace. First, give crystalloids such as Hartmann's. Think about red blood cells, which is the ideal in trauma, plus or minus colloids such as Haas. Remember the major hemorrhage protocol. Give warmed fluids, use O negative blood, and remember your ratios including FFP and platelets. You might need to think about giving vasopressors or inotropes such as metaraminol or noradrenaline, etc. The body has a number of coping mechanisms. Firstly, hemostasis. You'll form a platelet plug and initiate the coagulation cascade. The vessel may also go into vasospasm. Fluid shift from extravascular spaces. You may bleed internally or externally. Major internal bleeding includes hemoptysis, hematuria, GI tract, and AAA ruptures, which remember are retroperitoneal. External bleeding may be caused by surgery, postpartum, or trauma, and remember the floor and four more principle of TLS. So this can include chest, abdomen, pelvis, long bones, and the floor. And that's why it's important to log roll patients. The next principle is to stop the bleeding. I split this into physiological, pharmacological, and interventional. In physiological, you might want to accept a lower blood pressure to avoid disrupting a clot and optimize coagulation, as we said in ratios. In pharmacological, reverse anticoagulants with vitamin K, human prothrombin complex, or DOAC antidotes. Give tranexamic acid, stop any antihypertensives and anticoagulants. First, in interventional, elevate the bleeding area such as the limb, apply direct pressure, use an anticoagulant dressing if one's available in your emergency department, and in limbs, apply a tourniquet, but bear in mind that this is time critical. In the surgical interventions, achieve proximal control, use diathermy, clamps, sutures, and Surgicel. Interventional radiology may be able to embolize bleeding vessels. Finally, prioritize patient comfort. You may need to use sedation, consider ceilings of care, and whether a DNAR is appropriate.